So thanks, Jamie, and thanks for having us on this call. Like Jamie said, I'm Nick with ResMed. I've been with ResMed for just over 13 years. I look after our national accounts, but my history with ResMed has always been in Western Canada. So I'm a little bit familiar with some of the Saskatchewan programs and the different the pros and cons of that system. And so today, I'm going to share my screen with you. I don't want to keep you for the entire hour, but I promise to keep you riveted to the screen with this content. And this is really interesting stuff, and it is a conversation that we have quite frequently when it comes to when we talk about OSA. We do talk specifically about women, and we do talk differently about women OSA than we talk about men, and there are lots of challenges as well that come along with that. So just like Jamie was saying, so today we are going to talk about the prevalence of OSA in women. We're going to talk about some of the gender-specific risk factors and the differences in how symptoms present, and we're also going to talk about those health consequences of untreated OSA and the importance of personalized treatment approaches to improve outcomes and quality of life. Those are objectives today on the agenda. So a little bit about us, the prevalence, why women OSA, right? First, we really want to explore kind of why we're talking about this topic to begin with, talk about the signs and symptoms, the gender differences, and some of the solutions that are specifically designed for women by ResMed. Right? Because there's a history there of solutions, and we tend to talk about some of the challenges and some of the issues we see because we have a solution for it, right? Salespeople, huh? All right. So a little bit about us. So ResMed, as Jeannie mentioned, so we are leading the way in cloud-connected medical devices, right? So not only do we make CPAP machines, we make bi-level devices. We have a line of ventilators, but the bulk of our business is with CPAP machines. And since about 2013, they have officially been all connected. So every single device has a communications chip in it, which is why we call ourselves a cloud-connected medical device company. And specifically for the treatment of sleep apnea, but also COPD and other chronic diseases. And we're in 140 countries across the world, founded in Australia, manufactured in Australia and Singapore. Our North American head office is in San Diego, but we also have a big, beautiful office in Halifax, Nova Scotia, where we have some of our customer and technical support teams, and as well as our software developers, because a lot of what we do is also about software. Our mission primarily is not to toot our own horn, but we do create life-changing health technologies that people love, right? And we recently embarked on this amazing campaign to love your CPAP. I think Jamie, you'll share some of those examples at the end, but loving your CPAP is something that we've been really kind of wanted to take on because CPAP therapy is not an easy therapy to start, but once people start, we do find that they do love their therapy. So let's capitalize on that. Our vision, again, we want a world where every person can achieve their full potential through better sleep and breathing, right? And that's really important, and that's exactly what we want to do. Our impact, so this is really cool, actually. So 144 million plus lives changed in the last 12 months. 27 million plus cloud-connected devices in the market, right? We're talking about globally in the market. But what's really most interesting, what's powering everything is we talked about the communications capabilities of those devices. So every single device provides us capabilities to get data. So we have access to de-identified patient data, right? We don't know patients' names. That belongs to our customers. But what we have access to is the power of this data. So we have 22 billion patient nights of data, and that's what's guiding the innovation and guiding us to develop products better for patients. 22 billion nights, right? That's a lot. So when it comes to the prevalence of OSA, just to give you a quick background, and then we'll dive into specifically, women and OSA, but worldwide, estimated that there's 936 million people that have sleep apnea. Of those people, right, so from a moderate to severe perspective, right, 23.4% in women and 49.7% in men that are moderate to severe. Now, the scale varies a little bit, but for the most part, if you are moderate to severe, I would say you have sleep apnea. If you have mild sleep apnea, you still have sleep apnea. And we're going to talk about that today and some of the challenges that poses, especially with women. More than 80% of people with obstructive sleep apnea are undiagnosed and unaware they have it. So we've embarked on a lot more, education campaigns in the last few years just to educate the general public as well. Here's where it gets interesting. So post-menopause, right, the incidence of obstructive sleep apnea is 3.5 times higher in postmenopausal women. And now the mortality, so when it comes to mortality, severe OSA has been associated with a 1.9 times increased risk in all-cause mortality and 2.65 times increased risk of cardiovascular mortality. So that hopefully that highlights kind of the significance of OSA and how it's untreated, right? But most interestingly today, we're going to really be talking about not necessarily just postmenopause, but also just women and OSA in general, right? So the topic of why, and so why women and OSA, right? And traditionally, OSA has been considered a male disease, right? It was considered a middle-aged fat guy disease, right? And what we know now is that that is not the case, right? So recent studies have closely examined the condition in female patients and show that women experience greater negative effects of obstructive sleep apnea, right? So super important. So women are indeed more symptomatic, right? Women with mild OSA are more symptomatic and report worse quality of life than their male counterparts, despite having a lower apnea-hypopnea index. And when we dive into it, it'll make a lot more sense as to the why. Women scored worse than men when it comes to daytime sleepiness on the Epworth Sleepiness Scale, the ESS scale, which is a scale that's often used by physicians to establish like your level of sleepiness. Mental and physical health, right, the short form 36 quality of life scores were lower for women than that of men's. Women scored worse than men on the fatigue severity scale as well, and women experience higher levels of anxiety, depression, and insomnia, right? So hopefully we're starting to paint the picture a little bit more here as to the why. So when it comes to signs and symptoms of OSA in women, okay, typical symptoms, which we know, and a lot of physicians are very acutely aware of what those symptoms are, right? Snoring, witnessed apneas, and daytime sleepiness, right? Those are the things that we can all say, yeah, like if you have those things, typically you're likely to have OSA or at risk, and we're going to explore the diagnosis. But when it comes to women, so the typical symptoms in women include more insomnia, restless legs, fatigue and daytime sleepiness, depression, headaches, and muscle pain, right? The fact that these symptoms are so different is also why women are being misdiagnosed or underdiagnosed as well, right? So why is that the case, right? We know they present with different symptoms, but also women will also use different words to describe their symptoms. They're also less inclined to complain about tiredness or unladylike snoring, right? And they have a higher threshold for sleepiness. Even though they scored lower on all those things, they have a higher threshold for sleepiness. So fewer women are diagnosed, right? So this is an interesting, more of an interesting anecdotal evidence, but men are often accompanied to appointments by their partners, while women typically go to appointments on their own. That means that there is less available information about snoring or witnessed apneas. And that's for those similar situations. So even when women presented with the typical OSA symptoms, they were still less likely to be referred to sleep clinics. And that's because physicians tend to misdiagnose symptoms in women and may fail to respond to OSA symptoms specifically in women, right? Because what we know of OSA is a little bit of what we know in OSA in the traditional symptoms and the typical symptoms of men. This is an interesting study. So the aim of this study was to assess the differences in the clinical presentation between women and men with OSA. And this is really only, I mean, it's a nice chart with lots of numbers, but the conclusion is at the time of OSA diagnosis, women are more likely to be treated for depression, to have insomnia, and to have been diagnosed with hyperthyroidism than men with the same degree of OSA, right? So this is suggesting that perhaps the original diagnosis may have been incorrect, right? So we need to ask more questions and dive a little bit deeper into those symptoms. So the long-term consequences of OSA in women. So women with sleep disordered breathing, OSA being one of them, are more likely to develop dementia or cognitive impairment than those without. And female OSA patients experience more brain white matter injury than their male counterparts. It's a big deal, right? So when it comes to gender differences, so there are differences when it comes to the AHI, the apnea-hypopnea index. We look at apneas and we look at flow limitation. We also look at upper airway resistance as a way to measure and validate symptoms oftentimes. So women will have more, so they'll have a lower apnea-hypopnea index, shorter apneas, less severe hypopneas, more flow-limited breath, which are just partial collapses of the airway, and more REM-based events. So when we look at the study throughout the nights, typically more events happen in those, we see REM clusters later in the sleep stages. But women are often more symptomatic at lower AHIs than males with a similar disease severity. And we'll talk about kind of why that potentially could be. But the upper airway, let's look at the upper airway and the role of hormones, right? So women have smaller neck and upper airway than men. The airway of men with OSA is more collapsible than that in women's. Congratulations, all women, right? The mechanism is not entirely understood. But we do actually have a really good idea of what's going on. And it's likely that women have more upper airway muscle activity. And when we look specifically at menopause being an independent risk factor for the development of OSA, it implies that there's a protective role of the female hormones, right? Because when it comes to the differences between men and women, some of those things are very explainable. So why does the prevalence of OSA increase in postmenopausal women, right? So we can look at, again, the role of hormones and they play in the upper airway. So both progesterone and estrogen will play a big role in keeping the airway stronger. So progesterone is a known respiratory stimulant. The ventilatory drive and the response to hypoxia and hypercapnia is greater in the luteal phase when progesterone level is higher. And it decreases the upper airway resistance in the luteal phase. So we know that those hormones will keep your airway stronger and your airway will be protected when those hormones are at their peak. So in the luteal phase. And estrogen will also increase upper airway muscle activity of the dilator muscles, and it'll increase the chemoreceptor responsiveness in the first phase of the cycle. So estrogen will play a bigger role in the first part, and progesterone will play a bigger role in the second part, both kind of creating and protecting the airway more so. When it comes to flow limitation and OSA, so women with OSA have more episodes of flow limitations and upper airway resistance that do not meet the criteria for apneas. So the upper airway resistance and flow limitation. So it increases the work of breathing, right? My partial collapses will increase the work of breathing. It will cause arousals and disrupted sleep. It will affect daytime cognitive function, leads to insomnia, and produces daytime fatigue. Can lead to depression. So all those things now are making a little bit more sense that even though those events are not as severe, they are still leading to similar symptoms to OSA, right? The challenge that we're seeing is the severity of the AHI is not reflective of the symptoms women with OSA experience. And that is because the scoring criteria, when we're looking at the scoring criteria for an apnea, which is 10 seconds or more, we know that women have shorter apneas. So a 6, 7, 8 second apnea will not get counted in the calculation for the severity, right? So now it starts making a little bit more sense when we know that hormones play a role in protecting that airway, which means we have shorter events, which means they don't get calculated into the AHI, which means for the severity, women tend to present a lot more with mild sleep apnea. Mild sleep apnea is still sleep apnea, right? But the challenge is also that there's also a threshold for most funding bodies. So even for if you've got great coverage through your extended health benefits, those companies, as of 2016, most of them have a higher threshold for funding, meaning that your AHI has to be greater than 15 in order to receive funding for sleep apnea treatment. And that disproportionately affects women because, again, the AHI is not as reflective than men who present with traditional symptoms. So that's really the biggest challenge that we see in the market right now. It's we know that as long as we can still identify sleep apnea properly, we can still start educating a little bit more as to the benefits of therapy and some of the limitations that are in place for the scoring criteria and how women are diagnosed with OSA. Ultimately, we know that men and women who suffer from OSA should be studied and treated differently to ensure more effective therapy. So that's kind of what we were leading down the path before is ResMed does have a therapy that's designed specifically for women based on all these things that we know, right? So there's a specific device, the AirSense 11. Well, first of all, the AirSense 10 auto for her that started in 2013. And that was the first time that we had a specific auto for her mode that did things a little bit differently because we know that we can also treat women differently, right? So it is the only device on the market with an algorithm that's specifically designed to tailor to the breathing patterns of female patients. So there's a faster response to flow limited breaths, right? Because we know women have more flow limited breaths, even though they have less severe apneas, there's more flow limit breaths. So it means we have to respond more quickly to those things. The standard auto will have a 3-breath moving index and will respond breath by breath, but the for her mode will respond and look at 1 breath right away. There's a lower maximum pressure, right? Increased, it's paired with smaller pressure increments. So responding faster, but with smaller pressure increments. There's also a floor pressure that's based on the frequency of apneas and hypopneas. Again, that's specific to women. And the algorithm prioritizes the response to partial collapses and snore events above 12 centimeters of water. Those are just, I know those seem like, how does that work? But ultimately, they all work together to provide a lower average pressure with the same amount of treatment. Oh, also important to note that all the devices will detect and will give you a marker for residual events, but also residual rares, so respiratory effort-related arousals. And that's really important to give us an indication that if the mode really should be changed from a standard auto to an auto for her. Basically, it's giving us the marker that, hey, this algorithm is missing these flow limited events, and we're going to give you that marker in the report to say, hey, if we change it now to this from the standard to the auto for her, we know that all those events will be treated. And as a result, the for her algorithm will respond sooner, but with a gentler pressure increase, right? And that's really the important to highlight is with the single breath index, the device can do things more effectively. Some of the key takeaways. So now we know that OSA is not a disorder that's restricted to men. We know that women often present with complaints of fatigue, insomnia, morning headaches, right? Restless legs, depression. Those are all things we should look at in order, and good markers to say we do need to explore obstructive sleep apnea. Women are commonly underdiagnosed and are misdiagnosed with depression, insomnia, and hyperthyroidism. And ultimately, men and women who suffer from OSA should be studied and treated differently to ensure a more effective therapy. Right. That's what we have for you today. I hope this was helpful, and I know that this is a highlight summary, and we do have, sometimes we can go a little bit deeper into the algorithms and the whys and the studies, but hopefully this really gives you a good idea of the direction and some of the main points that we need to make sure to be looking at in the community, in our female patients, to ensure that they're properly diagnosed and properly treated.
Thank you. I appreciate that.
I will stop sharing and we can leave it open for questions.
Yeah. Well, it makes me feel, I feel a little bit more seen. I am not diagnosed with sleep apnea. I had testing. It was very, very mild, like almost non-existent. But if talking about hormones and hormone changes, I'm in that stage of life, and I feel like, there's weeks where I probably have sleep apnea and weeks I don't. And, it's just how do you figure that out, right? And by testing probably at the right time or right and the right week. And unfortunately, and that's hard to do sometimes in systems when you are on a wait list, right? And so
that's right. So there's two things that are essentially working against you. It's the timing of the test, and then it's the test itself in terms of what the scoring criteria for what the American Academy of Sleep Medicine considers an apnea, right? Because that is its definition that's rooted in research, but that research is rooted in men with OSA. So those scoring criteria haven't evolved since 2012. And so I think there is a bigger push to make sure that these are being addressed, right?
Yeah, and that's limited in the province, as you know. If you are mildly diagnosed with mild sleep apnea, so between 5 and 15 or 5 and 14 AHI, you don't necessarily meet criteria to get a government machine. And so that means unless you're at a high-risk job, which in my mind, if you're a mom, that's a high-risk job, or if you are driving a car, it's a high-risk job. I think you'd have to advocate for yourself a little bit to get funding for that machine by talking to whoever's doing the testing to arrange that. And also you don't get the auto set for her, obviously is not an option unless you have private insurance or can pay for it on your own.
It will be, I believe. So as part of the new cell contract, I do believe that it will be, because in the AirSense 11 Auto, both modes, the standard auto and the for her mode, and I know that with the new cell contract coming out, there's been a push as well to have both CPAP and autos within the program.
Yeah, well, hopefully that'll be a good announcement coming soon.
Yeah. And I also hope you feel more validated, right? Like, especially when it comes to like, hey, explaining the why, like why I have an AHI of 10, but I feel like I have an AHI of 30, right? And that's because your apneas are shorter. Your airway is still more protected based on hormones.
Totally makes sense. How do women, we get it so hard, I don't know what the story is, but I want to share a few things. First off, I was going to go right to some influencers on social media to show you some CPAP stuff, but I got to show you someone local in Saskatoon, and I hope this is the right one, but I'm going to share it right now. She talks a lot about how women never get into studies, right? Into medical studies. So I hope can you see this? And hear it. Hold on here. Might not be able to hear it yet. I might have to share computer sound. Here we go.
Female body. Do you have pain? No, you don't. You never really studied the female body.
Yeah. If you follow Faraday, she does a lot of these videos about how we've never studied the female body and how we need to start working on science, right? That will, help us feel better. So I want to thank Elizabeth, who we have on the call today. She was brave enough to share her sleep apnea story this last month and helps try and support some of the work we do in a fundraising campaign. And please, I'll pop her story into our chat here shortly so you can read it. You would have seen it on the email that you received for your e-blast for this presentation. But thank you, Elizabeth, for sharing your story. You can see it here. And all of our supports online as well that we have for sleep apnea. We have another one that Nick just told me about on Instagram and TikTok. Her name's Your Sleep BFF. It's another woman. She's called Your Sleep Girl and talks a lot about her sleep apnea treatment and how to fit your mask properly and how to clean properly. So a fun way of learning besides reading papers and stuff. So I'm looking forward to get into seeing her stuff.
And Lindsay is an RT as well. Yeah,
she's
so
an
a lot
RT?
of good experience. Yeah, absolutely. Yeah.
Yeah, so a respiratory therapist. Awesome. Yeah. And look, not a big girl, right? Like you're always thinking it's all about your weight or your neck and just like men, right? And no, that's not what we're seeing here. But we do, my favorite, this lady, she just came out with this and doing some support for ResMed here, but I got to show you Alicia. I'm just a big fan of her. So let's watch her little video she released this morning. Seemingly perfect timing for today's session.
It's a mini. It's an Air Mini. It's smaller than oh my God, it's so little. I was dreading to have to lug around my CPAP. It's not that it's big, but it's just, it's huge. Really, if you think about it. Look at this. I can CPAP on the go. Just me wearing my mask. What do you need that for? Nothing, just extra air. I might need this climbing the stairs in Santorini. I'm not gonna lie. This might not be a bad idea. Slip it into a backpack and wear my mask while huffing up the stairs. Give you a little extra boost. What? This is a little pocket CPAP. It's an awful big book for a little machine, I'll tell you that. Won't be reading this. Oh my God, I can use my CPAP on the plane. We're going to be on our way to Europe and I'm going to be snoozing. And I won't be bothering a single person. And I'll actually sleep.
CPAP, more like can barely see.
That. This is so exciting. This is where you're supposed to read directions. Oh my God, I'm so excited. If you would have told me at 22 that I'd be over the moon about a CPAP, I would have laughed in your face, but here I am. My day's better. My life's better. Listen, if you need to get a sleep test, go get it done. Stop being a weirdo. Oh, but I'm so worried about what? Better sleep? A better life? A better attitude? A better sex drive? Seems weird to be worried about that. I'm a lot nicer now that I sleep. Look at this. It fits in this tiny little... Are you kidding me? At sleep? CPAP. Going on a trip? Air Mini. I got so much garbage for my husband to take care of. Oh, this is a new mask. They sent me the F20. It's different than my regular mask, people. This is crazy.
You're just strap that on in the plane and people are going to be like, hey, you're supposed to be up in the cockpit.
Houston, we got zero problems.
Houston, I'm ready for a good night's sleep.
Oh, yeah. Yeah. Look what I got. Look what ResMed said.
That's very cool.
So fun, so relatable. Good on you for having her as a partner. I don't know. I feel, everyone feels seen with her for sure. I think just real person, right? So, fortunately, the AirFit Mini or the Air Mini is not funded by the SAIL program, but it's something you can purchase on your own online or at any of the local CPAP companies that you may partner with. So, questions in the chat here.
Yeah. Do you want me to answer those?
Yeah, I'm just gonna hit the stop button on recording here.